So I think we'll get started. We have a healthy number of people in the room and people still joining online. I think everybody has by now met Daniel Chamie. He's been here with us, I think, over a year now, leading the imaging core lab. He's obviously been a tremendous, boost and enhancement to the program. We want to do more than one imaging and physiology talk in this conference this year. Hopefully, we'd like to get into, a little bit more detailed stuff and nuanced stuff and different topics and niche areas. But certainly at this point in the academic year, I thought it would be great to get a, fundamentals talk from Daniel, which we're very, very excited about. If people have questions in the room or on the Zoom, I'm sure Daniel will be happy to field them as they come up. So we should try and make it as interactive as possible. And I'll hand it over to Daniel.
Okay, good morning, everyone. Thank you for the introduction. So today we're going to keep it, discuss a little bit the fundamentals and a lot of image interpretation, which are based on images that I acquired over my, my career as an interventionalist. So the principles of ultrasound, all you know. So an ultrasound wave is generated when an electric field is applied to an array of piezoelectric crystals that is located in transducer surface. So this electrostimulation causes mechanical distortion to the crystals, resulting in vibration, and that's what produces the sound waves, which are generated in pulses, and each pulse commonly consists of 2 or 3 cycles of same frequency. So basically what happens is those ultrasound waves are going to be emitted by the transducer and are going to be reflected back to the transducer according to each tissue type and component. So we basically have 2 types of IVUS catheter. One is a mechanical catheter that has one single transducer that rotates at 1800 RPMs at the tip, and an electronic catheter, which has 64 transducers that are displayed circumferentially around the catheter. So the basic differences are that the mechanical catheters, they have higher frequencies and shorter wavelengths. So usually the current mechanical catheters produce waves in the frequencies of 40 to 60 megahertz. So the higher the frequency, the higher the axial resolution we have, the lower the frequency, the lower the axial resolution we have. So the electronic catheters, which is represented by the Eagle Eye catheter that we have here in the cath lab, produces 20 megahertz of ultrasound waves, which are lower frequencies. So in summary, we have better images for mechanical catheters. Those catheters require saline flushing to provide a fluid pathway for the ultrasound. And the reason is that the catheter goes inside a sheath and the mechanical transducer is rotating. So we need a fluid-free pathway. The electronic catheter is easier to set up, as you all know, in the cath lab, has lower superficial resolution, but better penetration. So if the goal is to take a look in deep structures in the vessel. Sometimes we're doing CTOs where we park the ultrasound in the side branch and we need to take a look at the proximal cap in the other vessel. Maybe that's the catheter you want to use. So if you're looking at an ACS patient and you want to take a look at the morphology and if there's plaque rupture, maybe a mechanical catheter is a catheter you want to use. The electronic catheters have artifacts and imaging that can be problematic adjacent to the transducer, which is the near field ring down subtraction is necessary to be made. And I think this is consistent in the cath lab, so this is not a problem at all. So these are examples I collected from, representative images from the Eagle Eye catheter with 20 megahertz, the mechanical catheter from Boston with 40 megahertz. Actually, I think this is from Terumo, and the mechanical catheter with 60 megahertz from Boston. So I chose stented coronaries because I think it's going to be easier for you to appreciate the level of resolution as you look at the stent struts. So the electronic catheter with 20 megahertz, you see that the struts look much thicker and bulgier and kind of distorted as opposed to the mechanical catheter with 40 megahertz. You have better superficial resolution. You can see more of the interaction of the stent and the vessel wall. And the 60 megahertz, you have even finer stent struts there. You can see a little bit of malposition here. You can see the plaque behind and the external elastic lamina behind. So the catheter influences the quality of image that we have, and depending on what is the goal for the case, we should be mindful of which catheter we are using. So at Yale, we're doing the electronic with 20 megahertz, and we are doing the mechanical catheters with 60 megahertz. We have the option of using the Refinity catheter, which is also mechanical, and it gives us 45 megahertz, which is pretty close to this one. So OCT is an analogous of ultrasound, except that it measures the magnitude and echo time delay of light rather than sound. And the principle is pretty much the same. So you have a light traveling from the catheter, it hits the tissue, and depending on the tissue composition, it's going to be reflected back or it's going to penetrate more. So what we measure is the intensity that comes back and the delay that it produces. So the later the pulse wave is coming, the deeper the structure is in the vessel. Axial scans is a terminology that we use for OCT, which is for short A-scan, and it measures the back reflection, or what we are going to call now the back scattering of light as a function of a depth. So every time light hits a tissue, it's going to be scattered in all directions, and what the catheter measures is the light that is come back to the catheter, which is the back scattered light. And of course, as light goes inside the vessel, there will be some attenuation and some scattering, so the intensity goes down, and the intensity here is smaller than here in the surface. So we should expect brighter tissues in the surface as opposed to deep structure. But the decay in tissue intensity as a function of the delay where these the intensity here comes back to the catheter will give us a notion of how deep each structure is in the vessel. And the way, intravascular OCT is done is to generate a lot of axial scans on different transverse position. And then you have this, flat map of the vessel that is then reconstructed on 2D to become a cross-sectional image the way we are used to do. So a little more about the basics of how OCT is done. So opposed to IVUS, light cannot be measured real time. So the speed of light is so fast that we don't have any electronic device that can quantify how fast light goes in and out the tissue. So basically, OCT systems work with what we call the interferometer, which is this device here. So this is a laser source, and this is the time delay, but time domain OCT, which generated pulses of low coherence light. And what happens is you have an interferometer here that breaks the pulse into two halves. One goes to the coronary, which is the sample arm, and the other one goes through this path here, which is the reference arm, which is inside the box, the cart that we move in the cath lab. So I don't know what happened. So once the pulse breaks into two, the known distance by the reference arm will give us a notion of how deep its structure is. And you see that the mirror here, there is a mirror that moves, so you can get different depth in the vessel. Once the light comes back and cohere again, then it is sent to the computer, which generates the images that we have. So in the beginning, the need for movement of this mirror here to be able to capture different depths limited the clinical application of OCT, and OCT pullbacks were really, really small. The maximum they could get was up to 3 millimeters per second. So there was a need to occlude the vessel proximally, flush with saline, and the acquisition was done under saline flushing with a balloon occlusion in the proximal segment. So this is the system I started using when I did my training in 2007 and 8, and it was really painful for patients and really annoying to see, those ST elevations where I'll have some seconds of, balloon occlusion in the coronary. So technology evolved, and the trick here was we need to have this mirror stationary so we can speed up the process and get faster pullbacks. So the change was, instead of having single pulses that need to, have the same intensity, now the engineers came with what we call the frequency domain. And what happens is you have a laser source that have different bandwidth. So you have different, so the different bandwidths can give you different penetration. So the lower the wavelength, the more you can penetrate in the vessel, and the higher, the shallower it comes. So by changing the range of the wavelength, now the mirror can be stationary, and we can get different depths in the vessel according to how, according to the laser wavelength, as opposed to having to have a mechanical movement of the mirror. So this was the trick, to have faster OCT pullbacks that, allowed us to use it in clinical practice. Just a historical curiosity here. In terms of the technical comparison, the basic change you'll see is that OCT in general has 10 times higher resolution as opposed to IVUS. So here, the smaller numbers, the better. So we can see smaller structures. And for the first time, we're looking like the average of 12 micron structures in the coronary. So many things now can be seen that we were not used to see, but we just have to have in mind that this is a micrometer scale. And the lateral resolution is also much better than IVUS, which gives us more ability to identify nearby structures, adjacent structures. And the maximum frame rate is also much higher. So the system we operate today is 180 frames per second, which is much higher than the 30 frames per second, which is standard for IVUS. And this is what also allows us to have faster pullbacks of imaging. So the system we currently use allow us to go 80 millimeter per second or 36 millimeter per second if we do the survey mode, and that's what we usually choose. Pullback length, it's still longer with IVUS, which is a benefit. We see more of the vessel as opposed to the current Abbott OCT, which gives us 54 or 75. And tissue penetration is also favorable to IVUS. So we can see more of the vessel depending on which catheter you're using. So if it's the 20 megahertz catheter, you're going to see more dip in the vessel. If it's the 60 megahertz catheter, you see less of the vessel. But still, we are in the range of 8 to 10 millimeters. And tissue penetration by OCT goes up to 3 millimeters, depending on the plaque type. So there's not much penetration here. There's more penetration with IVUS. And the field of view, which was a problem for the first OCT technology, was limited to 6-7 millimeters. Is not a problem nowadays. So we can see up to 10 or even higher with the new generation OCT systems. So, SVGs, left mains, carotid arteries, peripheral vessels now are possible to be seen with OCT, same way we do with IVUS. And the catheter profile is pretty much the same. So it's in general 2.7 French for OCT and a little larger for IVUS, depending on which catheter you're using. I'd like to spend a few minutes describing the step-by-step for IVUS preparation. So, and I'm going to focus on the Boston Scientific mechanical catheter, which is the one that requires more preparation. The Eagle Eye catheter is just plug and play. We don't need to do much. So first thing is, unfolding the sterile bag that will come with the package. There are labels on the plastic bag. So there will be a faceplate sticker on one end and insert here on the other. So you just follow the instructions. You have a second person bagging the MDU, which is the unit that connects to the catheter. And then we connect, this faceplate to the catheter insertion, and using a rocking motion, you just attach the MDU to the sled, which is going to pull back the entire system. It's important to use, the 3-way stopcock here and a 10 cc syringe on one end and a 3 cc syringe, a medallion syringe that comes with a package on the other. And make sure that you don't have any air on the system on both ways. And then you connect this line here and you flush it as well with a smaller syringe, just to make sure that there's no air inside the tubing. Then it's time to flush the catheter. You remove the telescope here, you move it backwards, you connect the system to the side port of the catheter, and you flush. And this flushing has to be, exhaustive. So at least 3 times the full 3 cc syringe. One trick I usually use, once I remove the catheter from the hoop, I put the tip on, on the bucket with saline, and you just flush and you make sure that no bubbles are coming out. So this is a nice trick that you can just verify that there's no air, residual air inside the catheter. And then you connect to the MDU. So you remove the sticker and you connect the catheter to the MDU. And once you do that, the IVUS console should automatically recognize the catheter. So it's going to tell you that the catheter is connected to the MDU, and you can press this button here in the side to check the image. So it's always important to check, and this is the type of image you wanna see. So it's kind of a skin, onion skin around the core here. So that's the typical image once your catheter is, floating in the air, to make sure that the image is proper. There's no problem with the image. And then you just advance again the protective sheath and bring back the entire system, connecting here with the press and reset on this button here, and we are ready to go. So after preparation, make sure that you have given nitroglycerin. In case of obstructive lesions, what I usually like to do, even by not needing flushing the system, the vessel with IVUS, I always like to pre-dilate the lesion, give nitro, because we're going to have a better sense of the vessel size distal to the stenosis. Advance the IVUS catheter past the lesion or stent, at least 10 millimeters past the region of interest, so we can check on, proper landing zones if it's the pre-PCI run, or take a look at 10 millimeters past the stent and make sure that there's no dissection, there's no injury distal to the stent. So it's nice practice to have a little room distal to your region of interest. You trigger the pullback, which most of the times will be automatic for the mechanical catheter. So we have automatic pullback, and then we can benefit from length measurements, or a manual scan. If you're just focused on one, segment of the vessel, you can just manually scan the vessel. And then time for image interpretation. I cannot stress more the fact that the mechanical catheters require flushing extensively. So air bubbles inside the catheter harm the image. This is a horrible case with lots of air here. We don't see anything of the vessel. Sometimes we have these, ring down artifacts or reverberations, and you see that the reverberations come from the catheter, not the plaque behind. So this is all air which harm image quality, and then you open an IVUS catheter and you cannot do much with it. For OCT, we're gonna go over the step-by-step. Catheter preparation is easier. So basically we have, like IVUS, we have one side port here that we connect with a 3 cc syringe, and the recommendation is to use 100% contrast, a clean contrast media to flush. This flushing here is very, very hard because contrast is very viscous. The space between the sheath and the imaging core is very tight. So you need to really be, apply a strong flush here until you see at least 3 to 5 drops exit on the tip of the catheter. Just, be careful in handling. This is a very delicate, fiber optics here. So if you bend too much, if you touch too much the OCT lens, you may break the catheter. So just be mindful of where the length is and manipulate carefully when you're inserting in the guide wire. We connect the catheter to a dock station, and the dock will do the pullback the same way the MDU does for IVUS. So basically you insert and you rotate clockwise, and you see a sequence of LEDs blinking until this chain here is illuminated permanently without blinking. We'll see this other indicator here is illuminated, and the live view button will be green, steady green, so meaning that the connection has been properly done. Like for IVUS, give nitro before, and in case of obstructive lesion, now it's more important than for IVUS, pre-dilate before, because if the catheter is obstructing the lumen, when you inject contrast in the guiding catheter, you'll not be able to see past the lesion. So you're gonna miss the distal vessel. So we advanced the OCT past the lesion, same concept that I mentioned for IVUS, at least 5 to 10 millimeter past the region of interest, and the live mode may help optimize the length in case of stented vessels, and I'll show that in a moment. We need to be aware of the catheter landmarks. We have been operating with 2 different catheters. The OpStar have been recalled by Abbott, and we were working with the Optis. I think OpStar is back to market, so anytime soon we should have a new load of OpStar catheters. So the main difference is that the lens in OpStar is closer to the tip of the catheter as opposed to the Optis catheter. So it's 23 millimeters as opposed to 27, and in OpStar, the marker is just proximal to the lens, so you know where exactly you are. So just be mindful, and actually it's a good thing that the lens is closer to the tip, so we can see more of the vessel. So when you're imaging post-stent, one thing that I like to do to usually optimize the length that I'm going to image and minimize the amount of contrast that I'm going to use is to, on live view, you don't even need an X-ray, on. You just do live view on OCT. And if you see struts shining, so struts are so reflective that even the minimum amount of light that comes from the catheter goes through blood, and you can see that you're inside the stent. So you don't need any flash. So you see that you're inside the stent, and just looking at this image, you very gently push the catheter distal until you don't see those reflective structures anymore, and then you know that you're past the stent. So you know that you don't need to be too distal and spend more contrast. So just a little trick to optimize length and contrast volume. Blood clearance, you all know that we use regular guiding catheters, regular workhorse wires. The catheter goes like rapid exchange on the wire, and we just flush through the guiding catheter, and in a matter of 2 seconds, we have the imaging source coming in the opposite direction, which can be triggered automatically or manually by the operator. It's your preference. So it's that easy and it's that fast. For blood clearance, a little tips and tricks here. Just make sure that the guiding catheter is well engaged and coaxial to the target vessel, so you don't miss the volume that you're injecting to the aorta. Prefer 6 French catheters or higher, and no side holes because of the same reason. So if you do side holes, your volume is going to be lost on the holes. For left coronaries, this is what I do in my practice. I usually use a 20 cc syringe, not because I want more volume, but because it's going to be harder for me to inject. Sometimes those angiographic syringes are so easy to inject that you fill it with a 10 cc volume, and you can inject very fast. So you lose contrast very fast. So usually I fill it with 15 cc's.
Bypass surgery, 8-3-23.
And I try to inject those volume. And usually what I end up using is like 10 or 11 cc's out of these 15. So I just use 20 cc syringe to give me some more resistance in the left coronary and spare some contrast. In the RCA, usually a 10 cc syringe is enough. You don't have much side branches. It's more of a straight tube. So 10 cc syringe is enough to get a proper clearance. And if you advance in the use of OCT, you can see that using a 20 cc syringe with saline might be enough for most of the RCAs that we deal with. So you can skip contrast for RCAs with the system that we currently have. And once we have the spectral wave generation of OCT, we can do both coronaries with just saline without any contrast injected. I always recommend that since you're injecting contrast, you record a cine during OCT acquisition and keep your eyes on the OCT screen. We have the tendency, as operators, we tend to look at the angio when you inject. So when you start injecting, you see that the vessel is opacified by contrast, and you stop injecting because it's intuitive. But you still need 1 or 1.5 seconds more of injection to complete the run. So keep your eyes on the OCT screen until you see the catheter coming back to the guiding catheter. And then you can review the angio after completing acquisition because you saved it for recording. And optimize the contrast you use by acquiring those pullbacks in key moments during the procedure when you are already set to have an angiogram taken as part of your planning.
We had one question from Tom.
Sure.
Yeah, it was just last. Can you go to the last slide? So
yeah.
You mentioned like a previous slide. So how does it this one? So once you have the stunts in, how do you say the contrast volume? Because it's the same amount of contrast. It doesn't matter how far distal to the stunt, right?
Yeah, that's the thing. So if you're distal to the stent, if you're too distal to the stent, okay, then using the same amount of contrast, you might end up losing contrast for the proximal segment because you're going to inject. So you have to have more time to see all the distal vessel, which sometimes is not your interest here. And then you lose the proximal. So usually what I try to, just have 5 millimeters distal to the stent. That's why I use this trick. But then I benefit of coming back to the guiding catheter because, your catheter is always going back and inside and out. So I always like to check the entire vessel proximally because there is the segment of the vessel that you have more manipulation than the distal segment. And you save contrast because the more distal you go, more time you need the contrast column filling the vessel.
You have to inject a lot of contrast, to fill the
yeah. So this is one example. So this was the time of the BRS stent, the bioresorbable scaffold. So we did a stent in the circ. You have your guiding catheter. For a cine, this is enough. So you see the wire there, you see the OCT catheter. That's okay for an angiographic interpretation, but you see that there is a lot of escape of contrast to the aorta. There is a lot of recirculation back to the sinus of Valsalva. And then when you check the OCT run, which should be running. So I don't know why it's, okay. So you see the section there, but you see how much blood you have inside the vessel, and then you're going to have a swirl again. So this is an interpretable image, but not, the high quality we want, especially to assess, fine details after your intervention. So just be mindful of catheter engagement and coaxiality to the vessel you're looking at. And another thing that I always like to stress is that, again, the Abbott system needs catheter preparation. This will be eliminated with the spectral wave, but we need to flush and make sure that the core here is filled with blood. So this is a case that I usually like to show. Again, from the bioresorbable scaffold area, we were involved in many research at the time, and these patients were coming back for follow-up angios. For investigation of how the scaffolds were healing over time. So one of my colleagues had done 6 prior OCT runs, and each run he was increasing the volume because he couldn't see anything. He saw that there was a dismantling here, there was something funny happening there, but the image was all dark. So he called me after 6 runs have been taken, and if you look at the lumen is pretty dark. The problem here is a lot of blood in the catheter. So he never flushed the catheter. He ended up using 25 cc's of contrast per run, imagining that he was lacking contrast. And the problem was not the flush. The problem was catheter preparation. So after flushing the catheter with 10 cc of contrast, we managed to get this clear image, full of details, and crisp image here. So just be mindful of catheter preparation with the Abbott system when you use it, and flush the catheter and make sure that you have your core free of blood. It has to be dark like this. In terms of contrast, so this is the three most recent studies with OCT. Illumine 3, all you guys know, it's a randomization angio IVUS guided and OCT guidance. Opinion is a Japanese study that compared IVUS and OCT, and EyeSight is the one that I did in Brazil, again, comparing angio, IVUS, and OCT. And you see that the volumes we generally use are much smaller than, in the other studies. And if you take a look at the amount of contrast that we used for OCT-guided cases, which, computes the entire volume for the case, plus at least 2 runs, the pre and post, plus the case that you have some optimization and you do 3 or 4 runs, the amount of contrast that we dispensed to guide procedures with OCT is like half the ones that were used by angio in Illumine 3. So one thing that I usually like to, to reinforce here is the concept that many times we are mindful about the amount of contrast that we use for OCT, but we forget how much contrast we use just for angiographic guidance. So be mindful of the contrast in general and optimize the moments and the technique when you're using OCT, and then you are going to add much less contrast than you imagine for your, as compared to an angiographic guided procedure. So pullback, it's usually automatic for OCT. I usually prefer the long pullback, which is the survey mode, and this is one of the explanations. So we have the same vessel imaged with the high resolution pullback, which gives us 54 millimeters, and the long pullback in the survey mode, which gives us 75 millimeters. So you see a septal branch here, we see a diagonal here, and we see a lesion here. So I co-registered the septal and the diagonal branches, so you see that we are in the same position. The 75 gives us, of course, more vessel distal and more vessel proximal. And what is funny here is proximal to the stenosis, we have this lipid-rich plaque, and we don't have a proximal reference to guide the procedure. So if you do the 75, you can see the entire lipid-rich plaque, and you have this proximal landing zone that you could choose. So you can maybe move a little more proximal and have a safer and healthier landing zone. So just be mindful that longer pullbacks are preferable. And opposite to what people think, that you go longer and you use more contrast, the frame rate here is smaller. So you have half the frame rate. So it actually gives us almost 1 second less than the high resolution pullback, because you have less frames per second per millimeter. So actually you get longer with faster pullbacks, which allows us also to save contrast as opposed to high resolution. So this is the one I usually use. I only do the high resolution pullback if there is really a requirement for a 3D reconstruction. So if you're suspecting of a stent fracture or something that you really want fine details, so you want more frame per millimeter of the vessel, then you do a slower pullback and you have a higher longitudinal resolution. Stationary recording is also allowed in the system that we use, and this is one case that I did at the time that I was trying to nail the ostium. So this was one case that I tried to nail the LAD ostium. So I had a 7 French system. I put my OCT catheter in the circ, and this is a saline flush. So you see a lot of blood here. When I start injecting saline, you'll see my second guide wire and the stent here on the LAD ostium. So this is the type of image. So this is a stationary recording. You don't have a millimeter here. You have a second register. So you have 6 or 7 seconds of recording that you can benefit. And for, saline, this is pretty much what you need. So you just need fractions of a second to see where you are. So this is a pretty clear image in the ostium. And this is the, just the still picture showing my catheter in the circ. This is the circumflex wire. This is my LAD wire. And this is the stent just aligned at the ostium where I wanted. And then I delivered my stent. And always adjust calibration before you do any measurement. This is also always automatically done before the acquisition, but just make sure that your calibration is correct before you measure, so you don't make mistakes. The way to calibrate is, there is a calibration button in the left corner here. So you just move those two control buttons, and you have to have this blue circle surrounding the OCT catheter. And we don't want the markers inside the catheter. We don't want them too much outside. What we want are them aligned to the catheter. And just be mindful that sometimes you have to be a little bit inside here, a little bit outside. So it makes it proportional. It's not going to be centered. You cannot move those blue markers. So depending on where the catheter is in the vessel, you're going to be here. If you have any doubt, just measure the catheter outer sheet to outer sheet, and this has to be close to 0.9. This is the nominal thickness of the catheter we use. So every 1% change in the magnitude of the ideal calibration can result in 6 to 7% error in diameter and 12 to 14% error in area measurements. And this is one example I made. So this is the correct Z offset calibration. So you have the markers perfectly aligned to the catheter. So the area is 6.64, the mean diameter is 2.9. So on purpose, I made this very, very large as compared to the catheter. And now the catheter is much smaller. And for the same segment, the same region, I have now 18.7 smaller areas and 10% smaller diameters than I should have. And if I do the opposite, now I make the markers smaller and my catheter too big. Now I have an increment of 15.8% in area measurement and 7.5% in diameter. So just make sure that, check your calibration before you measure, especially when you're, measuring the landing zones to select your stent and balloons, because you don't over or underestimate the sizing. Moving on to image interpretation, and probably we're not going to be able to cover everything today, but we save it for another time. So the normal anatomy is usually made of 3 main layers: the tunica externa, or the external elastic lamina, the medial layer, and the intimal layer. And those 3 are possible to be seen by IVUS and OCT. Usually you have this 3-layer appearance. On IVUS, it's bright, dark, bright, and the same for OCT. So the intima is bright, the media is darker, and the adventitia here outside is bright as well. And the interface between the media and the intima is the internal elastic membrane, or lamina, and the interface between the media and the adventitia is the external elastic lamina. So the major atherosclerotic components by IVUS. So usually we refrain from trying to say the tissue type by IVUS. So we don't say fibrotic, lipidic, or whatever. We just describe the plaque. So, and the way to do it is we use the adventitia as our reference. So on IVUS, always the adventitia is the reference, and the plaque is going to be compared with the adventitia. So fibrotic plaques usually have the same echogenicity as the adventitia. Sometimes when the plaque has lower echogenicity as compared to the adventitia, this is called soft tissue. And soft means this could be lipid or loose fibrosis. When we see this darker than the adventitia, it doesn't mean that this is soft plaque mechanically. It can be very hard. It can be just a fibrosis with unorganized fibers that is really hard to expand. But I don't know why people made these names. So the nomenclature people use is a soft plaque, but mechanically it can be very hard. Calcified plaques are usually hyperechoic than the adventitia and produce shadow behind. So usually ultrasound bounces off these calcium surface and cannot penetrate there. So it creates a blooming artifact with shadow behind. And sometimes we have plaques that are also hyperechoic in comparison to the adventitia, but there's no shadowing. So just be mindful of these, and these can be dense fibrosis. So you expect some, difficulties in expanding a plaque like this. This can be also very hard. So for OCT, now instead of echogenicity, we look at 2 main things here to characterize everything. One is the backscattering that I described before, and backscattering is the intensity of light that reflects back to the catheter, and the attenuation. And we're going to play with these two concepts. So fibrotic plaques are usually high backscattering, so they are very bright, homogeneous, and they have a low attenuation because light can penetrate to fibrosis and allow us to see the deep layers of the vessel. We can follow the external elastic lamina here. So usually high backscattering, low attenuation. Lipidic, you see that a lipid plaque is all dark. So you have low backscattering and high attenuation because we don't see much. Everything is diffuse. We don't see boundaries. We don't see anything. So the problem with lipid is the high attenuation that generates, of course, so if the light is being all attenuated by the tissue, there's no much intensity coming back to the catheter. So this results in low backscattering. Calcified plaques, on the other hand, is also darker than the fibrotic tissue. So it has a low backscattering, but opposite to lipid, has also low attenuation. Light penetrates through calcium. So the reason why lipid is low backscattering is because of the high attenuation. So lipid attenuates everything. There's not much intensity to reflect back. Calcium, on the opposite, doesn't attenuate much, but scatter light in different directions. It can be forward scattering, lateral scattering, diagonal scattering, and less back scattering to the catheter. So it reflects less light as opposed to the fibrotic tissue. So that's why calcium is darker than the fibrosis. And since it has low attenuation, we can define the boundaries. So everything is clear, right? So we can see the EEL around, we can see the back border of calcium. And if you look inside, you see that the inside of calcium is also heterogeneous as opposed to fibrosis, which tends to be more homogeneous. Other morphological features, plaque rupture, and I tried to select one old case I had with a very nice rupture by IVUS, the same thing for OCT, and we don't need much description here to show this discontinuity in the luminal surface. You see a lot of lipid around. So this was an acute coronary syndrome case. So you have this continuity of this fibrous cap, the same thing here for IVUS. So the higher the resolution we have, the easier it will be to see those features by IVUS. And in both cases, we have a cavity that formed after rupture. Plaque erosion is something that it's very, very difficult to see by IVUS. It's a concept that emerged with OCT, and it's defined as thrombosis in the vessel attached to the wall without any sign of plaque rupture. So this is one of the nice cases I had with an erosion in a young lady. Spontaneous coronary artery dissection, we have images from IVUS and OCT here, and they are pretty much similar. What you see usually is this moon, this half moon-like structure. So you have there is an entry point somewhere in the vessel, so you have blood accumulating in the medial space, displacing the intima inwards and the adventitia outwards. The same thing here. You have the half moon-shaped hematoma pushing the intima into the lumen and the adventitia here outside. And this is all hematoma here. So this is a classic image for SCAD. I hope you guys don't forget anymore. So thrombus is usually a mass, unorganized structure that can be floating in the lumen, that can be attached to the vessel. It can be everywhere. It can be attached to the catheter or to stent struts. By OCT, we can also see different intensities here. So the red thrombus is usually very bright surface with a lot of scattering, because red thrombus or fresh thrombus is full of red blood cells that attenuate light. So we see that shadow behind. As time goes by, so this is a non-STEMI patient that I imaged like 48 hours after the event. So the thrombus here is more organized. You have more platelets, more fibrin, less red blood cells. So you can see the entire content of the thrombus. You can, you can see you can circle it, you can measure the area, and you can see behind. So we can also infer the timing of the thrombosis there. OCT allows us to also identify the vulnerable plaques which are called thin cap fibroateroma. And this is only possible with OCT because we have the ability to measure the thickness of the fibrous cap. So on this side of the vessel, you see the normal 3-layer aspect. We see some intimal thickening here. We see the media in the middle. We see the adventitia here outside. And then we have that high attenuation, low backscattering, no penetration of light. Everything is diffused. So this is a lipid pool here occupying 180 degrees of the vessel. And this bright surface here is the fibrous cap that overlies the lipid pool. So you can just zoom in, measure the thickness, and in this case, it measured 45 micron. So this is a thin cap fibroateroma, which is defined as a lipid pool with a cap thickness smaller than 65 micrometers. We can also see inflammation in the vessel, which is macrophage accumulation, which is characterized. So this is a deep lipid here, and we see usually these punctuate and bright structures that are brighter than the surrounding fibrotic tissue. So every time that you have a lipid-rich plaque full of these punctuated bright structures, this is also a lot of inflammation in the plaque. Neovessels can be these oval-like structures, usually close to the adventitia. Sometimes you have it more in the middle of the plaque. And these structures have been associated with two main things. One is you have now accelerated progression of atherosclerosis or stenosis because you have so much inflammation coming from these neovessels. And once those neovessels rupture, you may also have intraplaque hemorrhage, which is one of the causes of acute coronary syndrome. And cholesterol crystals are also a sign of inflammation here. Is this bright structure, a rod-like structure, different from the macrophage. So it's more of an elongated structure that is also brighter than the tissue. This is also a marker of inflammation and so on. Other morphology. So I just brought these two images because we had a recent case in the cath lab. So I think it's nice for us to recognize. This is one CTO that I did, many years ago. I thought that I was intraluminal when I checked to the retrograde injection, but I wasn't sure. I don't know why. So I decided to go down with the IVUS catheter, and I made sure. So my catheter is here on the outside. The true lumen is actually collapsed here. We have the medial layer here. We have the true lumen inside. So I was extraluminal, and I couldn't. So it was good for me to recognize that and not stand outside the lumen. So what I did, I waited for 2 months, and then when I imaged again, so these true lumen expanded back to its original position, and then I was able to, using a workhorse wire, just, complete the case. So I just delayed for 2 months my management.
That's for the fellows, this is a really important image, because even if you're not doing CTOs, there may be a point in your career where you're doing case visit, catheter-induced dissection, or some other scenario where you're not sure where your wire has true lumen and not dystrophy. And this is like pathognomonic, very characteristic of this true lumen is the squash structure, and you are not in the true lumen. So this is when you know to avoid stent. Just have this. So you'll see it a lot this year in your CTOs, but if you have it memorized, there'll be non-CTO cases, but it's very important that you can make that distinction, because if you can't and you then stent, then it's more or less an irretrievable catastrophe.
And actually, so what is nice about those pictures is this is much more common in CTO, but this right-hand case here was not a CTO case. So this was a regular lesion. I had one of my fellows, so, by the end of the year, just wire the vessel, I'm going to come in a minute. So while I was scrubbing, when I get in the room, the fellow is like, pale, and he says, Daniel, I just wired the vessel, I lost flow, and then everything is sluggish. So it was weird, and the lesion was actually very focal, and I don't know what he did, maybe a forceful manipulation of the wire. So he dissected the plaque and he exit extraluminal. So this is the true luminal collapsed by OCT. You see here the medial layer. So this can happen even on non-CTO cases. So just be mindful. So these are nice pictures to not good when you see it, but it's important to recognize those. So
if you are suspecting a dissection, is it safer in principle to use IVUS versus OCT just because you're not giving an injection?
Yeah, that is a concept that it's around for a long while. So I was wondering that many times you have dissections like this and you don't recognize, so you inject it like 3 or 4 times in angio in different views trying to identify, and we don't think about that. So I did one study that we are finishing the manuscript right now. So what I did is I took a pressure wire, a regular FFR wire, and I measured the intracoronary pressure during injection in multiple positions, in 5 positions along the vessel: the distal position, mid position, proximal position, at the catheter ostium, and inside the catheter. So what we found is when we hand inject, we generate a lot of pressures, usually above 300 millimeters of mercury inside the catheter. But once the contrast exits the catheter, it dissipates in the aorta. So we have, at the catheter tip, there is more than significant rise in pressure as opposed to the patient's average pressure. Once you get inside the vessel, there's no change in pressure, no significant change. So I would say that from a mechanical standpoint, it's kind of safer to inject. And actually, we use OCT to diagnose CADs and so on. To me, the problem is more of propagating dissections. In this case, is more of a matter of forcing the catheter distal, which can happen with OCT and IVUS. So the wires and catheters going down, as opposed to only the contrast going down, because you're giving angios one after the other, and you don't have those progressions. On CTOs, on the other hand, we are dealing on a closed compartment. So that's a totally different story. One thing is CAD, you have entry and exit point, so you have flow. On CTO, we're dealing with a closed compartment, and then I think we might generate all those pressures cannot dissipate, so they will be propagated, and then this becomes a problem, and we have huge intramural hematomas that can collapse the lumen, and we know the problems when we do CTO, so we avoid injecting antegrade. Before we finish this talk, I'd like to spend a little time on calcium. We do a lot of calcium PCIs here, a lot of calcium preparation. So we already saw how calcium looks like by IVUS and OCT. So again, what we can measure now by IVUS is the angle and the visual determination of its depth. This is the same calcification by OCT. You see that we have the same angle here, but now remember that light penetrates through calcium. We can see the entire thickness. This is the maximum thickness. This is the area. So if there in the future, if we have systems that derive the area in multiple cross sections, then you can have a volume over the length, and we can pretty clearly see the distance from the calcium surface to the lumen. So we see that there is some distance here, but in most of the calcified region here, the calcium is like in close contact with the lumen, so which is also very important for us, depending on which device you're going to use to prepare. There's one recent study, and I thank Dr. Fall for sending this reference to me. So this is a paper coming from CRF. They looked at 440 lesions. Actually, it's not that paper, Dr. Fall. There's another one, but this is one, this is a kind of older. So this is 2017, 440 lesions that they imaged with angiography, IVUS, and OCT. So when calcium is visible by angiography, in general, we have more circumferential calcium by IVUS, but you see that the numbers here are not that much different. So there is a lot of calcium that is not visible by angiography as well. And we're talking about over 200 degrees of calcium. So what is the main determinant of calcium visibility by angiography is its thickness. So look at the calcium thickness. When it's below 0.5 millimeters by OCT, usually you don't see those calcium. when the thickness is greater than 0.5, now we can see those calciums. And the thickness is also related to the final expansion that you can get. So the lower the thickness, the lower visibility by angel, the greater the expansion you'll find. One thing that is important, and actually it's kind of a novel concept that came out of this paper, is that thickness by OCT can be pretty well measured, as you can see on those two examples. But an indirect sign of thickness by IVUS is the presence of reverberation. So this is one of the examples from the paper, which you have on those arrowheads, a little reflection, a little reverberation of the calcium. And I'll show better examples of myself on the next slide. So reverberation is usually found in calcium by two main reasons. One, when the calcium is very superficial, you have a polished surface, and the ultrasound beam is kind of perpendicular to the calcium plate. So reverberations was always a sign of calcification. What this paper now is bringing as a novelty is that the smaller the thickness by OCT, the more reverberation you have in green here. So this is a sign also. The presence of reverberation can be a sign of thickness. So the more reverberation you have by IVUS, you can assume that this calcium shouldn't be that thick. It should be more towards a thinner side. So these are examples that examples of mine that I just brought to illustrate. This is a circumferential and thick calcium. You see a 360 degrees of calcification. There's no reverberation. Everything is black behind. This is one calcium that is not as circumferential as that. So it's almost half circumference. But you see these reverberations here. And if you measure the distance from the catheter to the surface, the distance from the catheter to the reverberation should be the double. So this is usually the double. It's more like when you get into an elevator and you have mirrors in front of and behind you and have multiple images of you, it's the same thing. So usually this was seen as a marker of calcification, but now we can also indirectly infer that this should be a thinner calcium than we expect. And deep calcification is a calcification that once you derive where is your lumen and where is your vessel, then you visually determine what is the plaque thickness. You get half the thickness, and if the calcium is located, in the deeper thickness of the plaque, this is deep. If it's in the proximal surface, it's superficial. So it's as simple as that. A little words about calcified nodules, so we can conclude this presentation. We have been dealing with two types of nodules. So nodular calcification in general is a calcified plaque that protrudes into the lumen. So it bulges into the lumen. So we can have a smooth surface like here, and this is the guide wire shadow, so please don't misinterpret. This is a smooth surface. This is a smooth surface here. The guide wire shadow is here. Or we have this very irregular surface, and better appreciated here on the OCT image. So this is what we call eruptive calcification. Usually we may have overlying thrombus in these eruptive calcifications, and very rarely we have thrombus attached to the surface of this non-eruptive calcification. And this is the reference that I was referring, that Dr. Fowl just sent me. We had a case this week that we were discussing, and he produced this recent publication in JACC. So these authors looked at 3,200 patients that were evaluable pre and post OCT, PCI with OCT. And out of those 3,200 patients, 236 had lesions with calcified nodules. So the prevalence is 7.3%. So which is kind of in line to what has been described by Renuvi Money many decades ago, which is 6 to 8% in prevalence. So this is 7.3. They excluded some, OCT, some cases that didn't have follow-up, and they found that percentage of eruptive and non-eruptive cases are pretty much similar. So 50% almost for each. And the distribution of eruptive and non-eruptive nodules, it's all also pretty much similar in the LED, regardless of where you're looking at, the left main. The only difference here is mid-RCAs have more eruptive calcified nodules as opposed to the other segments. So in RCAs, we should see more eruptive nodules in the middle, maybe because of the shear forces in that segment of the vessel. These authors also demonstrated that eruptive nodules can be better expanded by when you stent it, as opposed to non-eruptive. So non-eruptive are the chronic nodules, smooth surface. This generates less expansion. And when you look at the circumference of the vessel, we can deform. So you can have better circumferential expansion when you're dealing with eruptive. So you can have a more circular stent after it's stented, as opposed to the non-eruptive nodule where you have more elliptical shape of the stent. So this is more acute, this is more chronic. And what they found is, in terms of clinical outcomes, eruptive calcified nodules usually and significantly is associated with more recurrence of restenosis and reinterventions in the target lesion. So we saw that. We have 1 or 2 cases from Yale from last year that we stented eruptive nodules, and like in a couple of months, the patient was back with recurrence, and we could see the nodule protruding through the struts. So this is an entity that we are still learning how to manage, and we don't have the proper answers at the moment. There are 2 scoring systems to grade calcium. One by OCT looks at 3 variables: the calcium angle, and you look at more than 180 degrees. So if you have more than 180 degrees, you get 2 points. The maximum calcium thickness, more than 0.5, 1 point, and calcium length, more than 5 millimeter length, 1 point. So this is called the rule of 5 because it's 50% circumference, 0.5 millimeter thickness, 5 millimeter length. So you remember just the rule of 5. And these authors validated, and the higher the score, the worse the stent expansion you get. For IVUS, this is a more recent scoring following that by OCT. So they looked at 4 variables. So we look at calcium, the length of calcium that has more than 270 degrees for 5 millimeters of the vessel. So it has to be circumferential over 5 millimeters. If you have that, you have 1 point. If you have the presence of calcified nodule, which is not contemplated in the OCT score, you get 1 point. If the vessel is smaller than 3.5, 1 point. And if it's circumferential calcium, you get 1 point. And the cutoff to predict lower expansion is a score of 2 and above. And it's always important to, whatever technique you're going to use to modify calcium, it's always important to check if you really manage to modify. So these are examples that I have for, just non-compliant balloons. So usually what we have is we don't modify much the calcium, but we dissect the edges at the weakest point. Intravascular lithotripsy, you have a circumferential calcium here, and then after IVL, you see a little break here. And more important, if you take a look at the dip structure, you see now that ultrasound signal can pass through, as opposed to here that you have everything blacked out. So not only the fracture, and it's better to see movement, but also the presence of signal behind sometimes is a little trick that we can use to find these small fractures. And rotational atherectomy, here in this case, we have a small dissection here on this side, but a very polished surface, which is kind of circular, the shape of the burr, and followed by reverberation. So the reverberation, especially when you have a calcification like this, and then after atherectomy, you see that, it's a sign of debulking, right? So we are weakening the calcium. So the presence of reverberation and the drilling channel is, these are the hallmarks of rotational atherectomy. Some examples by OCT that I have for non-compliant balloon. This is a very thick calcification. I did just non-compliant balloons, and again, what you have is dissection. So there's some lumen growth, but by dissecting the edges, there's nothing happening with the calcium here. Cutting balloon, so this is my own experience, and we may discuss that. So once the calcium is circumferential and superficial, we may see these cracks of calcium at the weakest point. So you see the thickness here is much smaller than here. So the only effect I had was, on the thickest part when it's very, very superficial. Once you're dealing with eccentric calcification, we get the same thing as non-compliant balloons. We just dissect the edges. There's no much modification. And it's important to see the distance from the calcium surface to the lumen. Sometimes this is going to be deeper than the blades you have in the cutting balloon. So the blades are never going to touch the surface. So it's always important to take a look at that. Intravascular lithotripsy, this is the typical circumferential calcification. You see those large cracks. So there is one small here, fracture in the calcium as we would expect. And this is an old rotational thoracotomy case that I have with the old OCT system that required balloon occlusion. But what I like about this is that we could really see the drilling channel. And when you make the circular caliper, this was exactly the same size as the burr I used. So 1.5 millimeter. So you can see usually some fractures and these drilling channels. And I think we can finish.
Yeah, I think that was.
And then we can, there's so much more to discuss in imaging, how to prepare and, size, and we can use another.
I think that was absolutely terrific. I have ideas for maybe like 4 or 5 different separate imaging talks we can do. Just for the others on the call, 2 things quickly. Next week, we will have an external speaker. It's going to be Dr. Brolakis from Minneapolis Heart. It's going to speak about complications. We'll send an email out. Please do your best to be on that one. And then on the topic of imaging for the fellows, there are going to be 2 new trials presented at ESC in like a week. So Illumin 4, which is a very large RCT of OCT, in fact, 3 new trials, I should say, OCT versus angio. October, which is a randomized trial of bifurcation lesions, which is OCT versus angio again. And Octavus, which is a Korean trial from S.J. Park's group, which is randomizing OCT versus IVUS. So this is going to be the largest bolus of new data, randomized data for OCT. It's going to contribute most of the literature. If you guys want to get together and decide between you, maybe we can do a journal club of looking at specifically those trials presented at ESC and then all of the data for intravascular imaging and just synthesize it. We can plan to do that maybe in a session in November. I think that would be correct. All right, thank you again to Daniel. That was really good.